we're going to start talking about sedation. So when we talk about sedation, we have to talk sedation, right? We're going to talk about three intermingling circles like this. Okay? Anxiety, pain, and delirium. Okay? Anxiety is why we think about it this way, because there has to be each person has one of each. Like the majority of people has either anxiety or pain or delirium. Very few, small percentage have the two of them, pain and anxiety at the same time. Pain and delirium, and very small percentage have the three of them together. So we're talking about an agitated patient. Rarely you're gonna having the three all together, right? The problem, the problem is that when we hear that there is a patient that is agitated, everybody has his own medication. Give him Ativan, give him Seroquel, give him whatever, but we don't really diagnose and go and find out which one of those the patient has. For example, let's say the patient is having is demented, and he never talked to anybody for 2 years. This is non-communicative, right? You take him to the OR, you cut his leg, and now he's having pain. Do you think he's gonna snap out of his delirium and say, "Hey, doctor, I have pain," and then go back to become demented again? Of course he's not gonna do that. What he's gonna say is he's gonna be like a child. He's gonna be, there's something that hurts here. He's just like keep fiddling around, trying to take the dressing off or whatever. Maybe if I pull on that central line, the pain is gonna go away. Maybe if I jump off the bed, the pain is gonna go away. Something like this. So if we know that this is probably pain, then we give him a small amount of medication, and that will serve the purpose. If you don't want to consider that and keep giving him Ativan, you will eventually put him to sleep, but after you overdose him on Ativan, right? Same thing, if somebody's saying, "I'm seeing ghosts in a room," he's, diaphoretic and, anxious, and he looks like he's very anxious, huh? You can give him all the Ativan in the world, he might close his eyes, but he's still seeing the ghosts in the room, in his dream. But if you give him a small dose of Haldol, that will take the ghosts out of the room, right? Same thing, somebody saying, I feel like I'm impending doom, I feel like I'm gonna die, I feel this, I feel that. That's real anxiety. You're gonna give him Ativan, right? So that's very important. The problem is that there is a lot of anecdotes. Everybody has his own anecdotes. The nurses have his own anecdotes because of anxiety is treated with benzos. Pain is treated with opioids. And delirium is treated with psychomimetic medications. The problem is that if you give too much of benzos, you reach to hypnosis, sleep. Too much of opioids, you reach to hypnosis. And too much of psychomimetics, you reach to hypnosis. That means you sleep every time you give it, but you give a lot of it, the patient sleeps, so you don't know. So I'm sure you got signed out one day and they say, "Well, the patient was agitated. I give him, because he's old, I give him 0.5 of Haldol, and it didn't work. So I give him 2 milligrams of Dilaudid, and he slept." Of course, you overdosed the patient on Dilaudid. Of course. So that's the problem that we live in ICU. But this problem is not actually new. It's old. It's as old as cardiac surgery. Cardiac surgery started in 1950, open heart surgery, and from 1950 till 2000, we had a problem in cardiac surgery where the induction of anesthesia in cardiac surgery was sufentanil, and that's what I've done when I was young too. Sufentanil, 300 mics plus vecuronium, 10 milligram. That's the induction of anesthesia. Why did they choose sufentanil? And you notice there's no propofol, there's no etomidate, there's none of the induction agents. Huh? Because they chose that because it's a very stable anesthetic. It doesn't drop the blood pressure. Moreover, 300 mics of sufentanil is superfentanil, is equal 3,000 mics of fentanyl. 3,000, not 50, not 100. 3,000 mics, and the only reason we don't give 3,000 mics of fentanyl was because it's just going to take us too long to draw it. It's just too much. Huh? So so that's why we use the sufentanil. So with this huge amount of narcotics, the patient will go to sleep, get intubated, get swanned, get TEE, get the sternotomy, pump, off pump, and recovery room, and ICU for maybe 12 hours or so until you get extubated with one dose. This may be repeated, but this one you don't need to repeat. You don't even turn the gas. There's no anesthesia gas. So that was the anesthetic plan for for cardiac surgical patients. That's amazing, right? And they're stable, and you work, and everybody's happy. But that caused 1 to 5% of cardiac surgical patients reported recall under anesthesia. Because you're not giving him benzos, you're not giving him anything for amnesia, right? So they feel recall under anesthesia. And they go cry on TV and on Oprah or something, and then they just make tons of money. And rightfully so, right? They felt, they see, we heard everything, and we were terrified, and we feel, even we heard the sternal saw, they're cutting our chest. It's terrifying. And that's all because we use all this, level of narcotics and put them to sleep with narcotics. But let's say, and by the way, we got away with more than this. Like I guarantee you at least 50 to more than 50% of patients who actually had cardiac surgery from all these 50 years, from 1950 to 2000, at least more than 50 patients heard what's happening in the OR, at least. But we got away with a few things, like lucky. Some practices, not the practices I know, but some practices used to give a medication called scopolamine IV, which is actually taken off the market now because they give it to you the day before surgery, they bring you the day before, they give it to you, and you go in a delirious phase for about a week. Central anticholinergic syndrome, you keep doing like this, and then you can leave the hospital and everything is a blur, right? Obviously that's taken off the market. That helped us a little bit. Also, patients don't understand what we're saying. So even though they heard it, they can't repeat it. If you're professional in the room, if you're not professional and start talking about, regular stuff and nasty stuff, then they're gonna hear it and report you. Also, number 3, obviously patients most of the time are grateful because they have a new life, new heart, blah 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 blah. So they're not gonna report you. And also number 4, they don't know if they heard it in the recovery room or in the OR. So they really can't make a claim. They don't know. But I'm telling you, it's more than 50% heard it, right? So always think about it in compartmentalization like this. But if you're a malpractice lawyer defending the doctors, right? What question would you ask the plaintiff, the patient, that will discredit the patient, will make it look like the patient is lying or exaggerating? You will ask him, yeah, and how much pain did you have? He's gonna say a lot of pain. Of course, a lot of pain, because he wants to have more sympathy, right? He's a liar. You can't have any pain with 300 mics of sufentanil. That's a lot, right? And that is it.